Hi, I'm Morgan. This week I was given the assignment of viral encephalitis. Case information includes the chief complaint of, this is an 83-year-old male who presented to his internal medicine doctor yesterday with complaints of a mosquito bite that occurred 96 hours ago on a camping trip and that has caused right periorbital edema, headache, and mild fever. The internal medicine doctor recommended the patient take some ibuprofen to help with his pain and the swelling and to use ice on the bite itself to help reduce the swelling. The patient has been deferred to neurology and infectious disease due to the doctor's speculation of an arthropod transmitted infection. The doctor also recommended that the patient go to urgent care if his condition worsened before his appointment with neurology and infectious disease. The next day, the patient woke up with confusion and disorientation. His headache has significantly worsened since yesterday, and he has developed tremors. His wife has driven him into the urgent care. He has a past medical history of kidney transplant 18 months ago due to end-stage renal disease of about 10 years. He's been a type 1 diabetic since the age of 13. The patient also has coronary artery disease, chronic obstructive lung disease, and asthma. The patient takes several medications, including nitroglycerin, Theodur, albuterol, Atrovent, cyclosporine, prednisone, mycophenolate mofetil, and insulin NPH 16 units at breakfast and Lispro sliding scale at meals and at bedtime. He has an allergy to penicillin, which causes rash, hives, and difficulty breathing, vancomycin, which also causes rash, and sulfa drugs, which result in a rash as well. Today, he presents to urgent care with his wife for increased confusion and disorientation, mild tremors, and a worsened headache. Viral encephalitis is acute inflammation of the brain, usually of viral origin. It can be commonly caused by infections, autoimmunity, and post-infection problems. Approximately 70% of viral encephalitis is caused by a virus. About 3.5 to 7.5 out of 100,000 people will experience viral encephalitis. People who are more at risk include the elderly and young people, immunocompromised people such as those with AIDS, those that have undergone an organ transplant, or chemotherapy patients. The highest incidence occurs in the summer and usually in warm and humid climates where mosquitoes thrive and are very active. Arboviruses are the most commonly associated viruses with viral encephalitis. These include Eastern equine, Western equine, St. Louis, Venezuelan equine, Zika virus, and the West Nile virus. Infections like the West Nile virus can enter the central nervous system through the primary infection or through reactivation via latency. Antibodies can form in an autoimmune encephalitis, causing attacks on the cell's surface antigens, synapses antigens, and or intraneuronal antigens on specific neural cells in the brain. West Nile virus is the most frequent neuroinvasive infection and is transmitted primarily in the United States by the Culex mosquito. It can also be transmitted by blood transfusions and organ transplantation. The incubation period in humans is 2 to 14 days, and most individuals are asymptomatic at this point. 20% will have mild symptoms lasting 4 to 6 days. These include fever, headache, myalgias, skin rash, and lymphadenopathy. Less than 1% present with severe illness, but increased risk factors include advanced age, immunocompromised, diabetes, hypertension, and pregnancy. The pathophysiology of West Nile virus involves the viral transmission through the saliva of the mosquito during the bite. The virus invades the dermal dendritic cells and the keratinocytes, where the virus then replicates. The virus spreads into the bloodstream and lymphatic system and replicates in the lymph nodes and spreads to other organs. Viremia occurs and the virus passes through the blood-brain barrier and reproduces in the neurons. Once across the blood-brain barrier, the virus has access to the central nervous system, endothelium, and infects macrophages. The virus also travels along nerve endings through a process called axonal retrograde transport. This causes inflammation in the central nervous system, which leads to damage and loss of neurons in the spinal cord and in the brainstem's gray matter. This inflammation is clinically known as viral encephalitis, which leads to cerebral edema, vascular congestion, and intracranial hemorrhage if not treated. Case study 37 is acute viral encephalitis. The clinical manifestations include subjective data of the patient's wife's expression of patient being more confused and disoriented, and the patient's complaint of worsening headache since his office visit with his doctor yesterday. The chief complaint was reviewed earlier in the presentation, but includes the mosquito bite, mild fever, headache, and right periorbital swelling. The history of present illness involves his office visit yesterday, the MD recommendations of ibuprofen and ice to manage inflammation and pain, and the patient's worsening condition, which brought him to urgent care today. His diagnoses: type 1 diabetes, coronary artery disease, chronic obstructive lung disease, and asthma, and his status post-kidney transplant, and his daily medications play a key role in the progression of this case study. He is at severely increased risk for this disease process, mainly due to immunosuppression. Objectively, there is obvious confusion and disorientation and visible mild tremors. The patient's blood pressure is up to 150/95 from 140/95 yesterday. The patient's fever of 99.5 yesterday is now 100.5. The patient's pulse rate is slightly elevated. He is pale in color and ill-appearing. The physical assessment showed dry mucous membranes, mild pharyngitis, cervical and axillary lymph nodes that are enlarged upon palpation. An EKG showed sinus tachycardia. The patient is positive for Kernig's sign, which indicates meningeal inflammation or meningitis. The patient is also positive for Brudzinski's sign, which is also indicative of meningeal inflammation or meningitis. The patient also displays decreased muscular strength throughout. Lab results revealed an abnormal CBC with decreased lymphocytes, likely due to the extent of the viral infection present. The patient had a lumbar puncture performed, which revealed elevated protein and presence of IgM antibodies. These findings are characteristic of meningitis and encephalitis. The patient underwent an MRI, which showed cerebral edema without hemorrhage, and an enzyme immunoassay revealed presence of antibodies for West Nile virus, confirming diagnosis of acute viral encephalitis secondary to West Nile virus. The role of the advanced practice nurse in this case involves advocacy for immediate hospitalization in a critical care unit due to SIRS criteria and septicemia or viremia signs and symptoms. This patient has encephalitis and meningitis as evidenced by a positive Kernig's and Brudzinski's signs, fever, lumbar puncture, MRI, and immunoassay results. Intracranial pressure monitoring, or ICP, should be implemented to prevent more cerebral edema and eventual cerebral hemorrhage. Mannitol and steroids like dexamethasone may also be useful in decreasing ICP due to mannitol's ability to draw fluids from the brain into the bloodstream and steroids' anti-inflammatory properties. However, risks and benefits should be weighed when using steroids in this patient due to his already pre-existing immunosuppression. Neurochecks should be performed per policy to monitor changes in the level of consciousness. In this case study, West Nile virus is causing the encephalitis. There are no antivirals that treat this virus, so management of fever, dehydration, and headache is pertinent to foster healing and prevent further inflammation. Anticonvulsants may also be indicated for seizures associated with encephalitis. It is pertinent to provide a calm and low-stimulating environment for the patient to prevent further elevation of the ICP. Education regarding this disease process is a responsibility of the advanced practice nurse. Involving family and education in appropriate patient care can be helpful and can provide a less stress-inducing environment for the patient, which can also help to decrease ICP and aid in healing. The case questions I picked are: why are the patient's lymph nodes enlarged? The lymph nodes are likely swollen due to inflammation in the lymph nodes. As the virus replicates in the lymph nodes, the body's immune systems attempt to prevent infection from spreading by the acute inflammatory response. Vasodilation occurs, which causes plasma to leak through the vessels, leading to edema in the tissues, and decreases blood flow from those tissues to slow the production of the infection. Number 2 is what is indicated by a positive Kernig sign. A positive Kernig sign indicates irritation of the nerve roots in the spine, diagnostic of meningeal inflammation, which 3 medications taken by the patient can cause immunosuppression. The patient is on cyclosporine, likely taken to prevent organ transplant rejection due to his status post-kidney transplant 18 months ago. Prednisone is likely taken to reduce inflammation and also prevent organ rejection, with added benefit in preventing asthma attacks and lung disease exacerbation in this particular patient. And he's also taking mycophenolate mofetil, which is likely taken to prevent organ rejection as well. These are my references. Thank you for listening.